Hey, this is Dr. Padda. I wanted to talk a little bit about metabolic inflammation and how it relates to pain and how it relates to most disease processes that we deal with. I'm an anesthesiologist, but I'm also boarded in interventional pain and I'm boarded in addiction and obesity. So I have a perspective that's a little bit odd. I certainly started my world in anesthesia and did a pediatric anesthesia first. But as I transitioned into doing interventional pain, I realized that there wasn't a lot of durability in treatment. And I kept trying to figure out why. Why is it that I can identify the cause of somebody's symptom, I can get to the structure, and yet there's no durability in treatment? What do I need to do to fix that issue? And I was examining this, and eventually I started to wonder, well, could it be because obesity was playing a very significant component of this? And eventually I also asked myself, could there be hedonic substitution? Could people be taking pain medication, substituting for food, taking pain medication, substituting for food because they have some underlying issue? And all the while we were going through an opioid crisis in the United States, and it brought and accentuated this even more and forced me to look at it a little bit closer to better understand what's going on. So by necessity, I've had to look at the different pathways that are associated with this and how does it impact patient care. And that's what I really want to talk about. So when we're born, we consume a certain amount of healthcare resource. We become very productive up here, and then we slowly decline. The longer we spend in decline, the longer we spend in senescence, and the less time that we spend in productivity, the greater our healthcare expenditure is. And right now, the vast majority of people spend nearly 2/3 of their global life healthcare expenditure in the last 5 or 10% of their lives. So the vast majority of their expenditure is right here. And what's happening is that our population in the United States is getting sicker and sicker and sicker. In fact, at any given time, 93% of the adult population is metabolically ill. And of patients with pain, it's closer to 99%. I have a background in business as well. And so I always ask myself the question, how does this impact the global issues of economy, and how does it impact the treatment of patients? So about $1.3 trillion a year is spent on metabolic disease, and that's what causes early senescence. So people have looked at this, and if you have somebody who's healthy, who spends more time in productivity, more time in good health, that's not lifespan, that's health span. And we know that we can document a 9.2-year change in health span by improving lifestyle management. So this isn't drugs. This isn't some magic pill. This is having people eat better, being exposed to sunlight, having social interactions, and I'll kind of discuss those in a minute. But that's health span, and that's lifestyle coaching. And yet, as physicians, we spend almost no time doing lifestyle coaching. And Medicare recognizes that. They've looked at this and said, 40, 50%, 45% of the value of what we deliver is in this. And it's without medication. We need to figure out how to have physicians, and who are the leaders in the healthcare delivery system, increase the health span of these patients by coaching. Now, they don't pay us for that, or historically they didn't pay us for that, and so people gave this lip service. The first thing you're supposed to do if you have a patient with hypertension is to discuss with them lifestyle and issues that they can do to reduce hypertension. But I can tell you, on most patients that I've ever seen, the first thing that was prescribed was a medication, a beta blocker or an ACE inhibitor or some combination thereof, or diuretic. Nobody prescribed lifespan changes initially. Same thing with diabetes. The first thing you're supposed to prescribe, according to the American Diabetes Association, is a change in health. It's a change in health function. It's a change in health behavior. That's almost never done. Patients almost always are immediately started on medications for diabetes, and short shrift is given to counseling. That changed, though, in 2023. There are specific codes that Medicare initiated that allows us to do specific coaching and to have an ability to do it and to get compensation for it. Now, the problem is it's not good compensation. But the way that they set this up, it allows us to get compensation for care using ancillary services, using a secondary approach. It's not us personally delivering the care. we can use somebody who's well qualified, who's a non-physician, and they can get an NPI number and they can become a lifestyle coach. And so the Measura protocol, the protocol that we've created to help our patients, specifically leverages on that. And it avoids consuming the professional time of the physician. So health span is certainly one factor. But if you do this right, you can dramatically increase lifespan and health span. And that difference can be nearly 22 years. And that's what the ultimate goal is. Longevity and living as long as we can possibly live, and as well as we can possibly live, being hyper productive and doing everything we need to do to help society is what I would like to see. And that's been our goal in our clinic. So I'll talk a little bit about pain because that's what I specialized in initially. But this has wide applicability. I don't care if you're a psychiatrist, I don't care if you're a primary care, I don't care if you're a pediatrician, I don't care if you're an endocrinologist. Almost all of your patients will experience significant pain and discomfort because they're in the United States and they're metabolically unfit, and pain is the sentinel sign. See, the IASP, the International Association for the Study of Pain, has this long, drawn-out definition: unpleasant sensory and emotional experience associated or resembling or associated with actual or potential tissue damage. Yeah, what does that mean? It means something hurts. My definition is pain is the final pathway. It's the body screaming that something has gone terribly wrong, and now you better figure it out. And almost all patients, I don't care whether they're perfectly healthy or not healthy, in the United States, if they're metabolically unfit, the common pathway, the final common pathway is they're going to experience pain. So that's what you're going to see. They're going to be complaining of something. Unless they've had a head trauma and they're unconscious, they're going to be complaining of pain. And those are the patients that we can really help. Interesting thing, though, is that pain patients are refugees from their primary care. About 40.7% of primary cares will not take a pain patient back if they've been on opiates. Now, it's interesting, we had this whole opioid epidemic. The vast majority, however, of opioid epidemic was really a fentanyl epidemic. And yeah, there were patients who were put onto prescription pain medications, but that was at the behest of pharmaceutical companies that were making tremendous amounts of money on the sale of pharmaceuticals. They basically employed the physicians as high-priced salespeople and used their DEA licenses to push the consumption of narcotics out into the field. And it was under the Food and Drug Administration's guidelines, and it was under the CMS guidelines. And in fact, as an interventional pain physician, back in the days of OxyContin, which I hated, I didn't like using it at all. And in fact, I think I only wrote like 6 or 7 prescriptions of it when I realized very quickly it didn't work like I expected. Back in those days, it was very hard for me to convince a patient that they didn't need pain medication and that there was a way around this. Now, fortunately or unfortunately, things have changed, and patients now recognize that, hey, maybe I don't want to be on a narcotic. Now, certainly there are patients that need pain medication for acute symptoms. There's patients that need small amounts of pain medication. But if you overwhelm their system with high dosages of pain medications, it does nothing but suppress their endogenous opioid production, and their mu receptors are fully occupied. And then when pharmaceutically the level of opioid goes down, those people are screaming in pain, even though they may not have that much symptom because their own endorphins aren't being produced. So there's been a radical shift, and primary cares won't take pain patients back, even though they may have been the ones to start the patient on pain medication in the first place. They move them over to somewhere else, and then they don't want them back. And I understand that. We don't want to have them either on high-dose narcotic. Now, so what we try to do is we try to figure out the way around this. What's more interesting, though, is that there's a huge compounding effect with obesity. Not only is there a stigma with pain medication, there's also a stigma with patients having obesity. And that's one of the things that we deal with because the vast majority of our patients in our clinic have some form of obesity. Now, they may be normal weight, but they typically have sarcopenic wasting. And that's still a form of obesity. You can lose a bunch of weight, but lose more muscle mass than weight, and that can be a complication. And all of those things still feed into the same metabolic inflammation that we're dealing with. So we've known for a long time that the necessary precedence to having severe pain is inflammation. And it's primarily metabolic inflammation. And that's what drives cellular senescence. It's what drives secondary tissue damage. It's what drives fibrosis. And eventually, as you get all of these things, you get into the typical things that we see, which is kidney damage, heart damage, atherosclerotic cardiovascular disease, peripheral neuropathies, retinopathies, cognitive impairment. All of these things are secondary. They're all preceded by severe metabolic dysfunction. Now, this chronic metabolic inflammation is a balancing act. It's between the glycolysis and consumption of sugar anaerobically and oxidative phosphorylation. There's a switch, and it's the switch between M1 and M2 macrophages. M1 macrophages are pro-inflammatory. M2 macrophages are pro-resolving. And the thing is, the greater the M1 macrophage, the greater the amount of inflammatory cytokine, the greater the amount of leptin, the greater the fat mass, the more pro-inflammatory. And if you remember the Warburg effect, that's a glycolytic pathway. And that's why there's so many solid and soft tissue tumors and major organ tumors associated with the Warburg effect. And in fact, you can starve cancers by reducing the amount of sugars, by reducing the amount of glycolysis. Now, that's not the only factor, obviously, but that's a significant factor, and that has a lot of explanative issues associated with it that better help us understand the reliance of the cell on glycolysis and what we need to do for them. Now, historically, fat is intertwined with the humoral system. It's intertwined with the inflammatory system. Our fat body, which is if you look at the Drosophila model, which is a combination of fat storage, humoral production, red blood cell and white blood cell production, and immediate response, innate immune response, those are all intertwined in the fat body. In the human adult or in the human child, they've been pretty much separated out, and the bone marrow is where a lot of our red blood cells are made, and that's where a lot of our white blood cells are made. But yet, the adipose tissue remains a sentinel area where you can deal with acute inflammatory responses. And the fact is, the adipose tissue, the visceral adipose tissue that's in our gut, which surrounds most of our key organs, or especially our liver, it receives information before the rest of our body does, practically speaking, if you've consumed something that's a toxin. Now, obviously, that's different than airborne toxins, but we have a whole other defense mechanism inside our lungs. And we have mucociliary transports, and we've got white blood cells, but the white cells and the macrophages that are in the fat tissue interact. And that's where our tumor necrosis factor comes from. That's where our leptins emanate from. And the more fat cells we have, the greater our leptin concentration. I don't know if you remember, but during COVID, we had a slight issue. And that was because a lot of our metabolically inflamed individuals who had high amounts of visceral fat also had hyperleptin. And it's the leptin that's the potent inflammatory cytokine. And that was the triggering agent that seemed to aggravate a lot of the inflammatory response and probably aggravated the pulmonary edema that we were seeing. So historically, we've talked about a Mediterranean diet. So we've talked that the Mediterranean diet is the way to eat, but it's more than a Mediterranean diet. It's actually a Mediterranean lifestyle. It includes things like light, mental stimulation, social partnering, nature, physical activity. It's all of these things that are combined to give us a functionality. Without all of it, it doesn't work by itself. And I know that people say, oh, the Mediterranean diet is primarily a vegetarian diet. That couldn't be farther from the truth. The reality is the vegetarian diet certainly has a significant amount of vegetable matter, but it also has periods of intermittent fasting because the Mediterranean area has a tremendous religious orientation. And I can tell you that there's between 25 to 50 fasting days a year where people don't eat. And at the same time, they're exposed to light and they're exposed to a collegial atmosphere where they're hanging out with people that they like. So even though they may have some negative habits, some of them smoke, a lot of them drink, but the other factors, the lifestyle, seem to overwhelm it. Those same factors of smoking and drinking in the United States seem to not overwhelm our processed food diet, and that's why our senescence is a lot faster than it would be in the Mediterranean area. So it's not just me saying this. This is well known. The American Diabetes Association has all kinds of papers on this, and they go through all of the different pathways. But in essence, it's the adipocytes. It's all of the inflammatory cascade associated with obesity that really drives the inflammatory cascade for most of the metabolic dysfunction that we see. I wanted to talk a little bit about the the factors associated with this, because I think it's relevant. So I'm in the pain world, but I work with my orthopedic colleagues, and they're looking at these issues and they wonder, what's going on here? Why is it that patients have so many polyarthralgias? And why is it that we have so many people getting joint replacements? And what's going on? And I would conjecture that the metabolic inflammation is systemic. It's not localized to a joint. Yeah, certainly you're going to have more symptoms in a more load-bearing joint, and there is going to be more friction and more rubbing, and there is going to be more cartilaginous loss, and there is going to be an abnormality that you see. But the reality is that you can pick up the systemic metabolic inflammation by blood testing 8 years before you see X-ray changes. 8 to 10 years before, you'll see a molecular derangement. And what's interesting is even if you replace the total hip or replace the total knee, that patient's still going to have symptoms. Right now, about 50% of patients that have had total hip or total knee have significant symptoms at a year. 15% of them so bad that they're angry about it. And so even though you replace the structure of concern, the patient may not be perfectly better. Now, certainly they're walking better, their alignment is better, their load-bearing capacity is improved, but what got missed was the metabolism. And that's what we're here to fix. That's what we're trying to get to. There's a whole host of biomarkers, and there's recent studies, as recent as April and May of 2024, that go through all of these factors. They're interesting, and they certainly provide the factual information that we need to understand them. But you're not going to be measuring these clinically. There's no way that an insurance company is going to allow you to go off and measure a series of biomarkers and then use those biomarkers necessarily to make changes, because they're for research. Now, there are biomarkers that are not for research that are easily available, and those are the ones that we focus in on. But there's a whole host of other ones that are pretty specific, and they give you really good data. But that data is of limited utility for us. No matter what you do in these patients that have injuries, there's a whole other component, and that was that Mediterranean lifestyle I talked about. If you look at hazard ratios, smoking has a contribution. Support networks have a contribution. Socioeconomic status has a contribution. High levels of pain have a contribution. Catastrophizing has a contribution. Combined, they're massive. These are overlapped contributions. And if you add a few other things like loneliness, depression, pre-existing use of narcotics, they all have massive contributions for outcome. And so those are all lifestyle issues, and we can help fix those. If you look at all-cause mortality and you look at all-cause issues for frailty, the association with diet is massive. In fact, it's 80% of it. Arterial hypertension, diabetes, congestive heart failure, peripheral vascular disease, impaired sensorium, myocardial infarction. These are all things associated with lifestyle issues, dietary intake. And these are all significant, and we can address them. Preceding the heart disease, preceding the high blood pressure is a metabolic dysfunction. It's upstream of all of this stuff. And it really does represent 2/3 of the healthcare budget. 97 to 90%, 99% of metabolic dysfunction is attributable directly to lifestyle choice. About 87%, and it varies. The numbers are as low as 78.5 and they're as high as 87 point something. About 80%, let's say, of people that have type 2 diabetes and are insulin resistant, but are not on insulin, so they're undiagnosed, don't even know that they have it. They don't even suspect that they have it. They go in and they get testing, and all of a sudden they go, oh, I didn't even know my hemoglobin A1C was high enough to cause problems. The issue is that the testing that we use historically, like hemoglobin A1C, underestimates the risk of diabetes by 75%. Because what happens is it's the high insulin from the high sugars that actually drive the blood glucose down. So the hemoglobin A1C actually goes down first, and then it goes back up as you get beta cell depletion. So the initial component, the patient thinks they're doing pretty good, even though the high insulin is causing a issue of non-alcoholic fatty liver disease, or now called MAFLD, which is metabolically associated fatty liver disease. They're already getting injury to the peripheral nerves. They're already getting accumulation of damage in their blood vessels. Their nitric oxide system is already deficient. They may already be getting male impotence. They may already be sustaining significant renal damage, but they haven't gotten to the point where their hemoglobin A1C's gone up yet. And that's because it underestimates by 75%. And by the time that it does start to move up, they've got damage. That's why a lot of these patients have peripheral neuropathy symptoms years before they were diagnosed. It's not just heart disease. It's not just, oh, you have heart disease and therefore you have metabolic dysfunction. It includes everything from anxiety to depression, likely includes addiction. It includes schizophrenia. And you would never think that this included schizophrenia. But 75% of schizophrenic patients have metabolic dysfunction. And if you fix their metabolism, if you get them healthy, they quit hearing voices and you can take them off of their antipsychotics. That's nearly 75%. That was shocking to me when I realized that. So there's an entire field called nutritional psychiatry that's emerging that specifically addresses this, because we know that a lot of the SSRIs and a lot of the psychiatric medications don't work as well as we'd like. And we know that we want to get these patients off of benzodiazepines. And what benzodiazepines are really working on is a GABAergic system. And we can get to that GABAergic system by supplementing with GABA, restoring gut microbiome, and making the vagal nerve work like it's supposed to. And we can document it by a change in heart rate variability. So there are ways that we can get to this. And that's what Measura does. It allows us a pathway to help these patients, and it gives them a metric that they can shoot for. Because it's not just throw it all in a bag and go, you need to be metabolically healthy, because that doesn't make sense to the patients. You have to give them specific guidance, and that's what we're trying to do. If you have any questions, reach out to me. I'm happy to talk. We've got amazing protocols for lifestyle health. It makes a huge difference in patients. And we think that over time, if patients can really understand where they want to head, where they need to head, they'll comply. In my own clinic, we've taken patients who just got newly diagnosed with prediabetes, hemoglobin A1C 5.7 to 6.4, got enrolled into a lifestyle coaching program. I've dropped a CGM on their arm and said, look, all I want you to do is get this blood sugar below 105. And I'm going to explain to you what carbohydrates are. And if you avoid those carbohydrates, your blood sugar will drop. Almost all of them never needed medication. Almost all of them were avoided on going on to medication. So that's what we're trying to do. We're trying to use lifestyle to help coach our patients and get them to health. It's a cheaper way for the healthcare system. It's more efficient for the patient. It increases health span, and hopefully it increases lifespan, and it keeps people more functional. I don't want patients to have senescence. I don't want to have those long goodbyes. I want people to be extremely healthy, and I want them to be extremely healthy literally the whole time, because that's what gives people joy. If you have any questions, please reach out to me. I'd be happy to chat.